Let's go through the warm-up review. First question, which cardiac abnormality is associated with each of the following murmurs? So a systolic murmur, heard best in the second and third right intercostal space close to the sternum, is aortic stenosis. A rumbling late diastolic murmur with an opening snap is mitral stenosis. A pansystolic or holosystolic murmur at the fourth, fifth, and sixth left intercostal spaces adjacent to the sternum could be either tricuspid regurgitation or a VSD. And then a continuous machine-like murmur is a PDA. And then the last question says, outline the pathway by which stimulation of a GQ receptor activates protein kinase C. So GQ receptors activate phospholipase C, and then phospholipase C converts PIP2 to inositol triphosphate, or IP3, and diacylglycerol, or DAG. And then diacylglycerol activates protein kinase C. Now let's move on to the lecture.
In the next two videos, we'll be talking about pregnancy. This lecture will cover some of the pathologies that occur in early pregnancy, and we'll actually review a lot of embryogenesis as we go along. Let's start with twinning. There are two major categories of twins: monozygotic, sometimes called identical, and dizygotic, or fraternal. Dizygotic twins occur when two eggs are released and fertilized by two different sperm. Monozygotic twins come from one zygote that splits into two. And the timing of the split matters because it determines how many chorions and amnions there will be. The chorion and amnion are two of the fetal membranes that enclose the fetus. The amnion is the thin inner membrane, and the chorion is the thicker outer membrane. Remember that during the first 3 days after fertilization, the zygote undergoes successive cleavage divisions, becoming the morula. If the embryo splits during these cleavage divisions, it will produce two separate chorions and two separate amnions, so dichorionic, diamnionic twins. The morula enters the uterine cavity at around day 3 or 4. Then you have formation of an inner cell mass, which will become the fetus, and an outer trophoblast, which will form the fetal component of the placenta. And at this point, the embryo is called the blastocyst. If the embryo splits at this stage, the twins will have two separate amnions but share a chorion. We call that monochorionic diamnionic. On day 6, the blastocyst starts the process of implantation. By day 8, the inner cell mass gives rise to the bilaminar embryonic disc, made up of the hypoblast and the epiblast. Splitting of the bilaminar embryonic disc results in twins with both a shared chorion and a shared amnion, monochorionic, monoamnionic twins. Conjoined twins result if the split is incomplete. In practice, the more monos in a twin set, the higher risk of pregnancy. If you think of it this way, di-di twins have two placentas and two separate bags of water, two separate environments, essentially two separate pregnancies. Mono-di twins have one placenta and two separate bags of water, which means that this can lead to issues with one fetus stealing blood flow from the other, which is possible because they have the same power source, which can lead to selective growth restriction or anemia. Finally, mono twins have one placenta and one bag of water. Imagine, not only do they share the same power source, but the two fetuses are floating around in the same space, with their two umbilical cords floating around in the same area. The danger here is that this can unfortunately lead to fetal demise if the cords become entangled. Usually these pregnancies are delivered intentionally early to mitigate some of this risk. Now, what happens if the blastocyst implants in the wrong location? We call that ectopic pregnancy. Ectopic pregnancy is any pregnancy that's located outside of the uterine cavity. Most of these, in fact 98% of these, will be in the fallopian tube, most commonly in the ampulla of the fallopian tube, but ectopic pregnancies can also occur in the ovaries or in the abdomen. We worry most about the ones in the fallopian tubes though, because if the pregnancy grows large enough, it can cause the tube to rupture, leading to intra-abdominal hemorrhage and possibly even death. What are the risk factors for ectopic pregnancy? Well, we said that the majority of these occur in the fallopian tube, so most of your risk factors are going to be things that affect normal transport through the tubes. So the big ones are a prior ectopic pregnancy and a history of tubal surgery like a tubal ligation or reversal of a tubal ligation. A history of pelvic inflammatory disease increases your risk because PID causes scarring in the fallopian tubes. Smoking is a risk factor, probably because it impairs tubal motility. A history of infertility increases your risk. And then having an IUD in place. But be careful with that one. If you have an IUD, your overall rate of pregnancy will be lower, but if you do get pregnant, there is an increased risk that that pregnancy will be ectopic. Okay, so how do these patients present? Well, the classic triad for ectopic pregnancy is amenorrhea, vaginal bleeding, and ipsilateral abdominal pain. And then if that ectopic ruptures and there's intra-abdominal bleeding, patients can have severe abdominal pain or even referred pain to the shoulder. Sometimes they'll feel the urge to defecate from blood pooling in the pouch of Douglas. And then you also have to watch out for dizziness or loss of consciousness or any other signs of blood loss. On your physical exam, you might find lower abdominal tenderness and maybe an adnexal mass. But if the fallopian tube ruptures, you could see signs of peritonitis like rebound tenderness or guarding, which is why these are sometimes mistaken for appendicitis. Your workup should include a serum beta-HCG level and an ultrasound. The beta-HCG level will be elevated because the patient is pregnant, but the level may be lower than normal because these are not normal healthy pregnancies. The treatment for ectopic pregnancy is usually surgical, but in some cases you can use the medication methotrexate. You'll learn more about methotrexate in more detail later on in the course, but I'll just mention that methotrexate is a folic acid antagonist that inhibits dihydrofolate reductase, an enzyme involved in DNA synthesis. Let's move on and talk about gestational trophoblastic disease. Remember that the blastocyst has an inner cell mass that becomes the fetus, and then there's the outer trophoblast. And the trophoblast is composed of the cytotrophoblasts and the syncytiotrophoblasts. The syncytiotrophoblasts make up the layer that's closest to the mom. These are the cells that produce HCG. And they also invade into the endometrium and create the lacunae that fill with maternal blood. And then the cytotrophoblasts, which make up the layer closest to the fetus, form the chorionic villi, the finger-like projections that grow into these pools of blood. So exchange of oxygen and nutrients and wastes between the mom and the fetus can occur. So gestational trophoblastic disease arises from these cells, the cytotrophoblasts, which make up the chorionic villi, and the syncytiotrophoblasts, which secrete HCG. So one of the key points to remember is that gestational trophoblastic disease is associated with elevated levels of HCG. We break up gestational trophoblastic disease into three main categories: hydatiform moles, invasive moles, and choriocarcinoma. This is actually a spectrum of disease, with hydatiform moles being benign and producing a little bit of extra HCG, and choriocarcinomas being extremely malignant and producing a lot of extra HCG. Let's start by talking about hydatiform moles. There are two types, partial and complete. Both of these are due to abnormal fertilization. So there isn't normal fetal development, but the patients are pregnant. They'll feel pregnant. They'll have positive pregnancy tests. Partial moles occur when 2 sperm fertilize 1 egg, so there's an extra set of chromosomes. The karyotype is 69XXX, XXY, or XYY. And then complete moles result from 1 sperm fertilizing an empty egg and then duplicating its chromosomes, or from 2 sperm fertilizing an empty egg. In either case, you have a normal number of chromosomes. The karyotype is 46XX or 46XY. But don't let that deceive you. Complete moles are very abnormal. In fact, embryogenesis is so disrupted in complete moles that complete moles contain no fetal parts, whereas partial moles usually do. Both will contain chorionic villi on histology. Swollen hydropic villi are the hallmark of hydatiform moles. Grossly, the swollen villi look like grape-like clusters, and on ultrasound, this can produce a snowstorm appearance. In partial moles, the uterus is usually either normal size or smaller than you'd expect based on gestational age. Complete moles usually cause uterine enlargement. HCG production in partial moles is elevated, but it's even higher in complete moles. There is a smaller risk of partial moles becoming invasive, about 3 to 5%, but a larger risk with complete moles, 15 to 20%. And partial moles do not carry an increased risk of choriocarcinoma, but complete moles do, about 2.5% risk. So remember that complete moles are completely worse. The treatment for molar pregnancies is a DNC, dilation and curettage. Then we follow the HCG levels to make sure they go down to 0 and stay there. Now let's talk about invasive moles and choriocarcinoma. We said that both partial moles and complete moles can become invasive, but it's more common with complete moles. Invasive moles invade locally through the uterine wall. This can sometimes lead to uterine rupture and hemorrhage. Choriocarcinoma is the metastatic malignant form of gestational trophoblastic disease. Most, 50%, arise from complete hydatiform moles, but they can also occur after miscarriages, normal pregnancies, ectopic pregnancies, or even just spontaneously. Choriocarcinoma most frequently metastasizes to the lung, but it can also go to the vagina, brain, liver, and other organs. But definitely remember the lung. These most commonly present as a bloody brown discharge, but you can also have other symptoms such as dyspnea, depending on what organs are involved. With a normal pregnancy, it's normal to have some discharge after delivery, known as lochia. At first, it's bloody, but then becomes yellowish white before gradually resolving around 4 to 6 weeks postpartum. But a persistent brown, bloody discharge is abnormal. With choriocarcinoma, serum HCG levels will be extremely high. The treatment for invasive moles and choriocarcinoma is chemotherapy, usually including methotrexate, plus or minus surgery. And then, again, you'll follow the HCG levels. These are generally really responsive to chemotherapy, so the prognosis is usually excellent. Let's switch gears and talk about the umbilical cord. The umbilical cord contains 2 umbilical arteries and 1 umbilical vein, surrounded by a mucoid connective tissue called Wharton's jelly. Sometimes there's only a single umbilical artery, and this is associated with other fetal anomalies, but it can be an isolated finding as well. The 2 umbilical arteries carry deoxygenated blood from the fetus to the placenta, and the umbilical vein carries oxygenated blood from the placenta to the fetus. We cover fetal circulation elsewhere in the course. What I want to focus on are 2 other structures found within the umbilical cord, the urachus and the vitelline duct. During development, the proximal part of the allantois gives rise to the urachus, a duct that runs between the fetal bladder and the umbilicus. The urachus is supposed to involute after birth, becoming the median umbilical ligament. If it doesn't, if some or all of it persists, you can see a couple of things. If there's a remnant where the urachus meets the bladder, that's called a vesicourachal diverticulum. So that's a little outpouching of the bladder. If the urachus obliterates at the bladder and the umbilicus, but not in the middle, you can get a urachal cyst. And if the urachus doesn't obliterate at all, you get a patent urachus. You would suspect a patent urachus in a child with a persistently wet umbilicus because with these, urine continuously leaks from the umbilicus. The vitelline duct, also called the omphalomesenteric duct, connects the yolk sac to the lumen of the mid-gut. Normally, this connection disappears in week 6 of development. If it remains patent, you get a vitelline fistula, which connects the terminal ileum to the umbilicus. So these infants will have meconium coming from the umbilicus. If there's a small remnant at the ileum, this becomes a mecal diverticulum, an outpouching of the intestine. These sometimes contain gastric tissue, which can bleed, so these often present as a lower GI bleed. As you know, the fetus develops within the amniotic sac, which contains amniotic fluid. And the amniotic fluid is extremely important. It protects the fetus from trauma and gives it room to move and grow. The fetus swallows the amniotic fluid, which helps the GI tract develop. And the fetus breathes in the fluid, and that's essential for normal lung development. Having too little amniotic fluid is called oligohydramnios, and having too much fluid is called polyhydramnios. I wouldn't worry too much about the cutoffs or what qualifies as oligo or poly, but you need to know some of the causes of these. So, what are some of the causes of oligohydramnios? Well, in the second half of pregnancy, fetal urine becomes the most important source of amniotic fluid. So you want to think of things that decrease fetal urine output. Placental insufficiency. If the fetus isn't getting enough blood, it may shunt blood away from the kidneys, resulting in decreased urine production. Bilateral renal agenesis, where the kidneys don't develop normally. This can result in Potter sequence, where the infant has pulmonary hypoplasia and other congenital malformations due to this oligohydramnios. You'll learn more about Potter sequence in the renal section of this course. And then obstruction of urine flow, for example by posterior urethral valves in males, that can lead to oligohydramnios. And what are the causes of polyhydramnios? Here you want to think of things that would prevent the fetus from swallowing fluid, like esophageal or duodenal atresia, and anencephaly or some other CNS abnormality that would impair fetal swallowing. And also think of things that result in too much urine production. For example, multiple gestations. 2 fetuses will produce more urine than 1 fetus. Uncontrolled maternal diabetes, because this can result in glucosuria, then polyuria in the fetus as well. Certain congenital infections like parvovirus B19, and fetal anemia due to Rh alloimmunization. So one of the prenatal labs you always check is a type and screen to see if the mother is Rhd negative and therefore at risk for Rh alloimmunization. Let's talk about some of the other prenatal testing you can do. In the second trimester between 15 and 20 weeks, we can do maternal serum screening. This is known as the triple screen or the quadruple screen, depending on how many markers you test for. The main ones you look for are alpha-fetoprotein, AFP, estriol, which, remember, is the estrogen produced by the placenta, and HCG. And then you can add on inhibin to make it a quad screen. So you measure these markers in the mom's serum, and abnormal levels can point to a problem with the fetus. What causes an elevated AFP? Abdominal wall defects like gastroschisis or omphalocele, neural tube defects, multiple gestations, incorrect dating. With trisomy 18, Edwards syndrome, all the markers are down. AFP, estriol, and HCG are all decreased. With trisomy 21, Down syndrome, you'll see decreased AFP, decreased estriol, and increased HCG. And inhibin is increased as well. Adding inhibin improves the sensitivity of the test. So maternal serum screening is used for screening. We also have a couple of tests that are helpful for diagnosis. Amniocentesis is where you insert a needle into the amniotic sac and take out some of the amniotic fluid. The fluid will contain some fetal cells that can be karyotyped, so this is actually used to test for aneuploidies or genetic diseases. In the past, we also used to measure AFP and acetylcholinesterase levels by amniocentesis to confirm a neural tube defect, but nowadays we mostly use sono to do that. Chorionic villus sampling, or CVS, is another invasive diagnostic test that's used for fetal karyotyping and genetic testing. The advantage of CVS is that it can be done earlier in pregnancy, between 10 and 13 weeks. Cell-free fetal DNA testing, which can be used to determine fetal sex early, in addition to providing an early screening modality for aneuploidy. I want to finish this lecture by talking about some of the physiologic changes that take place during pregnancy. Obviously, there are a number of big changes, but I want to focus on just a few. Take a look in your study guide. You don't need to memorize these numbers, but be comfortable with the concepts. The first one says basal metabolic rate increases 10 to 20%. And this is in order to meet the demands of the growing fetus. So pregnant women have increased caloric requirements. That's pretty intuitive. Next, plasma volume expands by 30 to 50%, and red blood cell mass increases by 20 to 30%. This protects the mother from the blood loss that will occur with delivery. The increase in blood volume can manifest as some changes on cardiac auscultation. 90% of pregnant women will have a systolic ejection murmur, a flow murmur, and some will have an S3 heart sound. And then, because there's more blood for the heart to pump, the cardiac output increases by 30 to 50%. What's the formula for cardiac output? Stroke volume times heart rate. So this increase in cardiac output comes from both an increase in stroke volume and an increase in heart rate. Next, blood pressure decreases in early pregnancy, reaches an nadir at 24 to 26 weeks, and returns to pre-pregnancy levels by term. So this becomes important when you talk about hypertension in pregnancy, which we'll cover in the next lecture. Increased GFR leads to a decrease in BUN and creatinine. And the last one, increased procoagulation factors leads to a hypercoagulable state. So during pregnancy, and actually in the first few weeks postpartum as well, women are at increased risk for DVT and PE. Okay, that's it for the lecture. Now it's time for the end of session quiz. What are the risk factors for ectopic pregnancy? Prior ectopic pregnancy, history of tubal surgery, history of PID, smoking, infertility, and IUD in place. Next, which type of ovarian cyst is associated with molar pregnancies? We didn't talk about this, but remember, molar pregnancies are associated with elevated levels of HCG. And which ovarian cyst occurs because of high levels of HCG? That's the theca-lutein cyst. Next, what is the most common location for metastasis in choriocarcinoma? The lung. So think of choriocarcinoma in a patient with shortness of breath and an elevated HCG level after pregnancy. Next, failed involution of what embryological structure is associated with each of the following statements? Drainage of urine from the umbilicus, urachus. Drainage of meconium from the umbilicus, vitelline or omphalomesenteric duct. Next, what condition is suggested by each of the following abnormalities on second trimester maternal serum screening? Elevated AFP, neural tube defects, abdominal wall defects, such as gastroschisis omphalocele, multiple gestations, incorrect dating. Low AFP, low estriol, and high HCG. That's trisomy 21, Down syndrome. And lastly, low AFP, low estriol, and low HCG. That's trisomy 18, Edwards syndrome. And we have one rapid fire fact. Snowstorm appearance on ultrasound is a hydatiform mole. Okay, that's it for this video. I'll see you next time.